Today, we are going to understand aspergillosis, a clinically important fungal infection that ranges from mild allergic disease to life-threatening invasive illness. This topic is extremely high yield for exams and crucial in real-world clinical practice, especially in immunocompromised patients. Let's start with the pathogenesis and mechanism of infection. Aspergillosis is caused by Aspergillus species, with Aspergillus fumigatus being the most common and most important pathogen. These fungi are ubiquitous in the environment. They are found in soil, decaying vegetation, dust, and even indoor air. Infection begins when a person inhales fungal spores, also known as conidia, from the environment. These spores travel through the respiratory tract and reach the alveoli of the lungs. In a healthy individual, the immune system, especially alveolar macrophages and neutrophils, quickly destroys these spores. However, in individuals with weakened immunity, particularly those with neutropenia, prolonged corticosteroid use, or other immunocompromised states, the spores are not cleared effectively. Instead, they begin to germinate into hyphae, which are long, branching fungal filaments. These hyphae can invade surrounding tissues and, importantly, they can invade blood vessels, a process known as angioinvasion. Angioinvasion leads to tissue infarction, necrosis, and even hemorrhage, making invasive aspergillosis a highly dangerous condition. So remember this key idea. Backhand index pointing, right inhaled spores, plus impaired immunity equals invasive fungal disease. Now let's move on to the clinical presentation and types of aspergillosis. Aspergillosis is not a single disease. It presents in multiple forms depending on the host's immune status. The most severe form is invasive aspergillosis. This typically occurs in immunocompromised patients. These patients present with fever, chest pain, cough, and hemoptysis, which is coughing up blood. This form progresses rapidly and can be life-threatening if not treated early. Next is Aspergilloma, also known as a fungus ball. This occurs when Aspergillus colonizes a pre-existing lung cavity, such as one formed by tuberculosis. Patients may be asymptomatic, but a classic symptom is hemoptysis, which can sometimes be massive. Then we have allergic bronchopulmonary aspergillosis, or ABPA. This is a hypersensitivity reaction to Aspergillus, typically seen in patients with asthma or cystic fibrosis. These patients present with wheezing, cough, eosinophilia, and worsening asthma symptoms. Finally, there is chronic pulmonary aspergillosis, which develops over time and presents with chronic cough, weight loss, fatigue, and progressive lung damage. So the spectrum ranges from allergic right arrow colonizing invasive disease, depending on the immune status. Now let's move to the diagnostic criteria and testing, which are extremely important for both exams and clinical practice. One of the first steps is microscopy and culture. Samples such as sputum, bronchoalveolar lavage, or tissue biopsy can be examined under the microscope. The classic finding is narrow, septate hyphae with acute angle branching, typically around 45 degrees. This is a hallmark feature of Aspergillus. Next is imaging, especially a CT scan of the chest. Two classic radiological signs are frequently tested. The first is the halo sign, which represents a nodule surrounded by ground glass opacity, indicating hemorrhage around a lesion. The second is the air crescent sign, which appears later and indicates healing with cavitation. These findings are particularly important in diagnosing invasive aspergillosis. Another important test is the Galactomannan assay, a blood test that detects a component of the Aspergillus cell wall. This test is especially useful in neutropenic patients and can help in early diagnosis. Additionally, the beta-D-glucan test may be positive. However, it is a panfungal marker, meaning it is not specific for Aspergillus. So remember, backhand index pointing right microscopy shows branching hyphae, backhand index pointing right CT shows halo or air crescent signs, backhand index pointing right Galactomannan helps confirm diagnosis. Now let's discuss the treatment strategies. The first-line treatment for invasive aspergillosis is Voriconazole. It is the drug of choice due to its effectiveness and relatively better safety profile. Another important option is Voriconazole, which is also used in invasive disease. If these are not suitable, lipid formulations of amphotericin B can be used as an alternative. Treatment is usually prolonged, often lasting several weeks to months depending on severity. For Aspergilloma, if the patient is symptomatic, especially with recurrent hemoptysis, surgical removal of the fungus ball may be required. In high-risk patients, such as those with severe immunosuppression, antifungal prophylaxis may be considered. Now let's move on to preventive and lifestyle measures. Since Aspergillus is found in the environment, prevention focuses on reducing exposure. High-risk individuals should avoid environments with construction dust, soil, compost, and decaying organic matter. Using protective equipment like an N95 mask can reduce inhalation of spores. In hospital settings, especially for immunocompromised patients, staying in HEPA-filtered rooms is recommended. Wearing gloves and practicing proper hygiene when handling soil or plants is also important. Monitoring immune status and minimizing immunosuppression when possible can further reduce risk. Finally, let's go over some high-yield reminders and complications. One of the most important points is backhand index pointing right early diagnosis and treatment are critical for survival. Invasive aspergillosis has a high mortality rate, especially if diagnosis is delayed. A major complication is massive hemoptysis due to angioinvasion of blood vessels. The infection can also disseminate to other organs, including the brain, heart, kidneys, and skin. CNS involvement is particularly dangerous and often fatal. When treating with drugs like Voriconazole, it is important to monitor drug levels and watch for drug interactions. Direct hit final summary aspergillosis is a fungal infection caused by Aspergillus species, primarily affecting the lungs after inhalation of spores. It ranges from allergic reactions to life-threatening invasive disease, especially in immunocompromised patients. Diagnosis relies on microscopy, imaging, and serological tests, while treatment centers on voriconazole and other antifungals. Early recognition, proper treatment, and preventive strategies are key to improving outcomes.